Dr. M. A. Sophie M.D., FRCP, London, Frkpeden, Eden. Pericarditis. Dr. M. A. Sophie M.D., FRCP, London, Frkpeden, Eden. Pericarditis Introduction. Pericardium is a fibroelastic sac made up of visceral and parietal layers separated by a potential space, the pericardial cavity. In healthy individuals, the pericardial cavity contains 15 to 50 milliliters of an ultrafiltrate of plasma. Pericardial diseases are relatively common and present either as a manifestation of a systemic disorder or as isolated disease. Diseases of the pericardium present clinically in one of several ways. Acute and recurrent pericarditis. Pericardial effusion without major hemodynamic compromise. Cardiac tamponade. Constrictive pericarditis. Effusive constrictive pericarditis. Acute pericarditis. Pericardial effusion. Acute pericarditis refers to inflammation of the pericardial sac. The term myopericarditis, or perimyocarditis, is used for cases of acute pericarditis that also demonstrate myocardial inflammation. Diseases of the pericardium present clinically in one of several ways. Acute pericarditis is an inflammation of the pericardium characterized by chest pain, pericardial friction rub, and serial ECG changes. Manifestations include chest pain, typically sharp and pleuritic, improved by sitting up and leaning forward. Pericardial friction rub, a superficial scratchy or squeaking sound best heard with the diaphragm of the stethoscope over the left sternal border. Electrocardiogram, ECG, changes, new widespread ST elevation or PR depression. Pericardial effusion. Chest pain, the vast majority of patients with acute pericarditis present with chest pain, greater than 95% of cases. Sharp and stabbing pain, caused by the heart rubbing against the pericardium. May increase with coughing, swallowing, deep breathing or lying flat. Can be relieved by sitting up and leaning forward. Patient may need to bend over or hold to chest to breathe more comfortably. Pericardial friction rub. Pericardial friction rub is highly specific for acute pericarditis. Occurs during the maximal movement of the heart, are generated by friction between the two inflamed layers of the pericardium. Other symptoms include pain in the back, neck or left shoulder. Difficulty breathing when lying down. Anxiety or fatigue. A dry cough. Electrocardiogram in acute pericarditis showing diffuse upsloping SD segment elevations seen best here in leads 2, 3, of, and V2 to V6. Cardiac auscultation supine and leaning forward. Auscultation of the pericardium. To elicit pericardial rubs, the patient is invited to lean forward, A, or rest on elbows and knees, B. Both physical maneuvers increase the contact of visceral and parietal pericardium. Characteristic. Parameter. Pericarditis. Myocardial infarction. Pain description. Sharp, pleuritic, retrosternal, under the sternum, or left precordial, left chest, pain. Crushing, pressure-like, heavy pain. Described as elephant on the chest. Radiation. Pain radiates to the trapezius ridge, to the lowest portion of the scapula on the back, or no radiation. Pain radiates to the jaw, or the left arm, or does not rad. Exertion. Does not change the pain. Can increase the pain. Position. Pain is worse in the supine position or upon inspiration, breathing in. Not positional. Onset/duration. Sudden pain, that lasts for hours or sometimes days before a patient comes to the ER. Sudden or chronically worsening pain that can come and go in paroxysms, or it can last for hours before the patient decides to come to the ER. Pericarditis can be classified. Classification. Pericarditis can be classified according to the composition of the fluid. Types of pericarditis include the following: serous, purulent, fibrinous, caseous, hemorrhagic. Acute versus chronic. Depending on the time of presentation and duration, pericarditis is divided into acute and chronic forms. Acute pericarditis is more common than chronic pericarditis. Chronic pericarditis, however, is less common, a form of which is constrictive pericarditis. Clinically: acute, less than 6 weeks. Subacute, 6 weeks to 6 months. Chronic, greater than 6 months. Acute pericarditis. Causes of pericarditis include the following: idiopathic causes. Infectious conditions, such as viral, bacterial, and tuberculous infections. Inflammatory disorders, such as RA, SLE, scleroderma, and rheumatic fever. Metabolic disorders, such as renal failure, hypothyroidism, and hypercholesterolemia. Cardiovascular disorders, such as acute ME, Dressler syndrome, and aortic dissection. Miscellaneous causes, such as iatrogenic, neoplasms, drugs, irradiation, cardiovascular procedures, and trauma. Laboratory and imaging findings. Echocardiography. Echocardiography is often normal in acute pericarditis unless associated with pericardial effusion. Finding of a pericardial effusion supports the diagnosis. The absence or other echocardiographic abnormalities does not exclude it. CXR is only helpful with effusions greater than 250 milliliters. Small effusions, less than a few hundred milliliters, may present with a normal cardiac silhouette. Lab tests may include CBC, serum electrolyte, blood urea nitrogen, BUN, and creatinine levels, lactate dehydrogenase, LDH, and serum glutamoxaloacidic transaminase, SCT, AST, levels. Signs of inflammation, ESRNC reactive protein, CRP, levels, and cardiac biomarker measurements. Increases in serum biomarkers of myocardial injury such as cardiac troponin I or T. Indications for pericardiocentesis and pericardial biopsy. Studies in patients with acute pericarditis have reported a low yield for diagnostic pericardiocentesis and pericardial biopsy. Some authors have advocated for a more extensive use of these techniques for diagnostic purposes. The majority of patients with uncomplicated acute pericarditis do not require invasive pericardial procedures. However, some high-risk patients may require pericardiocentesis for both therapeutic and diagnostic purposes. Pericardiocentesis. Pericardiocentesis, in patients with a pericardial effusion, pericardiocentesis or surgical drainage can serve both diagnostic and therapeutic purposes. Decisions regarding drainage of the pericardial space are based upon the presence of an associated effusion, its echocardiographic characteristics, e.g., size and composition, and clinical significance, e.g., causing hemodynamic compromise. Patients with symptomatic effusions and evidence of cardiac tamponade should undergo prompt pericardial drainage. When a significant pericardial effusion is present. Large effusions refractory to medical treatment. Effusions that are small to moderate in size generally do not require drainage, unless a sample of the effusion is necessary for diagnostic purposes. Indications for invasive workup in acute pericarditis. Pericardiocentesis. Pericardial biopsy. 1. Cardiac tamponade. Relapsing cardiac tamponade. 2. Moderate to large effusions refractory to medical therapy and with severe symptoms. 2. Suspected bacterial or neoplastic pericarditis. 3. Suspected bacterial or 3. Worsening pericarditis despite medical therapy. Without a specific diagnosis, pericardial effusion. Echocardiogram. Diagnostic considerations. Costochondritis, or other non-cardiac chest pain. Pericarditis may occur after renal transplantation, which may be related to uremia or infections, e.g., cytomegalovirus, CMV. Liver disease has been noted in asymptomatic constrictive pericarditis. Small asymptomatic pericardial effusions in patients with AIDS syndrome may not require diagnostic evaluation. Large symptomatic pericardial effusions should be investigated, because 2/3 of such effusions are potentially infections or neoplasms. Tuberculous pericarditis can also occur. Tension pneumothorax may mimic cardiac tamponade. Differentiating pericarditis from acute ME, coronary artery vasospasm, esophageal rupture, esophageal spasm. Differential diagnosis: angina pectoris, aortic dissection, aortic stenosis, coronary artery vasospasm, esophageal rupture, esophageal spasm, esophagitis, gastritis, acute, gastroesophageal reflux disease, myocardial infarction, myocardial ischemia, peptic ulcer disease, pulmonary embolism. O2 and cardiac monitoring. Rule out life-threatening. Management. O2 and cardiac monitoring. Rule out life-threatening. Myocardial infarction. Aortic dissection. Evaluate for evidence of hemodynamic instability. Consider whether further management is safe to continue on an OPD basis. Avoid NSAIDs and corticosteroids in acute ME pericarditis, because they may interfere with ventricular healing, remodeling, or both. Poor prognostic factors. Myopericarditis. Severe pericardial effusion. Cardiac tamponade. Transfer to a hospital setting in which hemodialysis and cardiothoracic surgery are available. Pericardiocentesis. People with effusions larger than 250 milliliters, effusions in which size increases. Pericardiectomy is the most effective surgical procedure for managing large effusions.